So one of the things that I get asked about all the time on the stream now, especially because I've had hand pain in the past and I've talked about it on the stream, is essentially like, what do you do for, physical problems like pain problems or, aches and, or, weird nerve sensation sort of stuff, if you do a lot of programming or really any job that involves sitting down and typing most of the day. There's sort of this undercurrent of everyone sort of has these problems, but nobody really knows that much about them in our industry, and we don't really know necessarily what to do. And you might go on the internet and do some searches or something and find some kind of a WebMD page with some ads on the side, and you read the symptoms and you're like, okay, maybe this is what I have. Maybe I should do this weird thing that they're saying or something. But what we do at Molly Rocket whenever we have any sort of a problem with physical things related to work is we ask Dr. Emily Sherb. So I asked her to come today and talk to all of us about, essentially like what's the real beginner, the novice introduction from a medical professional to people who don't really know anything about this, about how to like diagnose and think about these problems so that they can essentially get the medical help that they need, right? If you understand more what's happening with your anatomy and more what's happening with your nervous system, all sort of stuff, you can ask the right professional to help you and have some idea of where you need to go or what you might need to do to stop having these kinds of problems. Yeah, without further ado, Dr. Emily Sherb.
Good morning.
So first of all, I'll give us a little bit of background. Since we don't know anything about you here, I obviously know you personally, but what got you into this profession? What got you into like diagnosing sort of these sorts of problems and helping people with them? Because obviously you do a lot more than just sort of problems that programmers might have or something. I know you do a lot of work with like circus performers and all these other sorts of things. So give us a little background there.
I grew up kind of being a very physical person and always was an athlete and a gymnast specifically and a dancer. And got into circus when I was a kid, and I've always been a person who watches movement and enjoys movement, and I kind of knew I wanted to do something with human bodies and movement. So eventually, after spending too much time, or just the right amount of time performing and playing around the world, I went back to school, and I am now a doctor of physical therapy, which basically means I like movement. So it all comes around full circle. A physical therapist, what we do, which I think most people don't actually know, is we are movement diagnosticians. So we look at the anatomy, we look at the biomechanics, and we problem solve how all that works together and plays together to give you the symptoms or your pain or just the weird way you walk down the street. So walking in front of my office is always interesting because I'm always staring at everyone going, ooh, that's weird, that's weird. But yeah, so that's kind of my quick background. I love working with anybody who moves, which is pretty much everybody. And I just find it really interesting. It's kind of like what you guys do. So you are faced with a problem you need to find the answer to, and you are problem solving. It's the same thing from my end. It's all physics and engineering, levers, pulleys. The human body is a really interesting, simple machine.
So you run your own practice now, and I was curious. So do you see a lot of people come in with kind of pain or injuries related to doing work at a computer? Is that a common thing that you have, or is it the kind of thing that people just don't really know to seek help for or going to the wrong places for?
It's really interesting because I'd say most of the people I see have pain due to the way they are working, whether or not they know it or not. So even if my circus people are coming in, usually. Yeah. So I treat a lot of circus performers, both students and performers here in the Seattle community. And most of the circus students are not full-time circus performers, and they spend their week sitting at their desk and then their evenings and weekends flying around on things. And usually what they're coming in for is certainly contributed to by how they're sitting at their desk and all the things they do like this, and then they all of a sudden want to do this. And they don't realize that what we train our body for every day is the things that we do. So if you're practicing this all the time, this becomes what you're good at, even if it's not a great shape for your body. And more specifically, what you're asking is, do people come in for this? Sometimes.
Okay.
It's hard to answer because I don't know who I'm not seeing.
Okay, that's a good point.
So
you don't know how
the
many
people that come into me, yeah, absolutely. Every single person that comes in with pain from work is totally coming in from pain from work.
That's a good point. Okay, so essentially what you're saying there is that even though someone may not be coming in and saying, hey, I'm having problems, I type all day and I get this pain in my wrist or something, you do get situations where like someone comes in and says, I'm having pain for this thing that I do on the weekend, and I think it's that, and you're like, yeah, okay, and you're kind of like this and stuff, and I can see that like probably part of the problem is just your musculature is not,
Yeah. Or sometimes I see people who come in and I'm chatting with them about stuff, they're like, oh yeah, and I have this thing when I'm working.
I see. So it's kind of like a little bit of a doorway question there, or whatever they call it, where it's like kind of like, oh, by the way, here's the actual thing, and I didn't mention that as part of the thing.
Right, because they don't think of it as a thing because it just happens every day. Or
Right.
I had patients come in and they're like, oh yeah, and this thing, but it's been happening to me since I was 15 or 16.
Okay.
And
Okay.
That's still a thing.
Okay. Just because it's been happening to you since you're 15 does not mean it's not involved.
Does not mean it's a normal occurrence.
So let's dive into the sort of science part here. I have a list of stuff that you sort of sent me that was like, here's the sorts of things we should probably talk about. And I think I'm just going to start with those because you kind of know, like, I don't even have like a basic understanding really of how these sorts of things fit together. So I feel like I can't really put them in a good order. So tell me if I'm going out of you. Don't feel like you have to go in this order. I'm just going to kind of go by the sorts of things you talked about so that I, hopefully set them up right. So the first thing that you were talking about is diagnosis versus symptoms. That's what you were saying. And you specifically mentioned the fact that like doctors label symptoms, not causes or something like that. You said something there and I wasn't really sure what you meant. So could you maybe start with that and tell us a little about like the diagnosis symptoms thing and what you were thinking about there?
Sure. So your traditional primary care doctor or often orthopedist that you go into and say, hey, I have low back pain when I am at the computer. And they're going to go, great, you have a diagnosis of low back pain. But what is that really? Low back pain is a symptom. What's causing the low back pain? Why is it there? If I look at someone with low back pain, I'm like, well, obviously it's musculoskeletal. It's how they're moving. It's what they're doing. Though low back pain could be a lot of other medical conditions that have a side effect of low back pain or that as a symptom. So a lot of our medical system currently doesn't have a good language around musculoskeletal pain, and we're still kind of learning and kind of developing that language. So a lot of the diagnoses traditionally are not really helpful. They're a description of what you're experiencing, but they're really not causational. So again, this is kind of what I was talking about with physical therapists as movement diagnostics, is we're kind of filling in that void of I have a diagnosis system, not all. Physical therapy is growing and changing, so there are many different diagnostic systems. But the diagnostic system I use, for example, with low back pain is, I diagnose by the cause, movement cause. So, okay, you have low back pain. Do you have it because every time you bend forward and that's a stressor that bothers you, or every time you get a rotation, which could be because you're moving your arm and that's pulling on your back? So it's a rotation diagnosis or a flexion diagnosis or the different movement orientations of the back. But knowing and understanding that what you're experiencing might just be a symptom of something going on more globally in your body is really kind of important. I know Casey's talked a lot about self-diagnosis of carpal tunnel syndrome, and we'll kind of hopefully get to that later.
Yes.
But is that because of something happening at your wrist? Is that because of something happening at your elbow, at your shoulder, at your neck? There can be lots of different causes for the same diagnosis.
Yeah, and I feel like that's one of those sort of memes that got around was carpal tunnel syndrome. So now people just, if they're having some general problem here, they're like, I must have carpal. Like, it's kind of this unfortunate thing where they just think that, and maybe that has something to do with it, maybe it doesn't, or they don't even necessarily know what they should be doing. Like, do I need to get surgery for this all of a sudden or something, and not necessarily know. But yeah, I guess we can put that down when we get to, you had the common ailments section here. On the diagnosis versus symptoms thing, so is it the case generally that, if you go to like a primary care physician, is it sort of like just, well, if you happen to get one who knows about, movement mechanics or something, they may go, oh, I should probably refer you to somebody who's going to take a look at this more carefully, versus someone who just doesn't think along those lines and just goes like, okay, prescribe some, aspirin or something. Like, when you go to a primary care physician, is it generally the case that they would be expected to properly refer you in the case of a mechanical problem, or is that just kind of hit or miss?
It's hard to say. I have to say in Seattle we've got great primary care docs in general, and usually they're going to look at it and be like, and think, okay, that is musculoskeletal problem, and they're really great at referring out to physical therapy, orthopedists, whatever they think is appropriate. Primary care docs are amazing because they have such a wide breadth of knowledge, and their job is really to point you down the correct avenue and the correct pathway. So a good primary care doc, is gonna either say, I think this is solvable with conservative treatment, whether that's take these NSAIDs, go home, ice, whatever, and come back later and then we'll see, or whether that's sending you on to another practitioner. My feeling is, why try to mask it again with ice and
because presumably it will just come back, whatever you were doing.
But generally, if it's a more long-term problem through repetitive stress injury, they tend to come back. If you fell down the stairs, you don't tend to fall down the stairs repeatedly, so that's going to be something that is easily
If you do
solvable.
fall down the stairs repeatedly, that's probably something you should be referred to a specialist as well. And again, just finally on that note there, it's like, so if you want to get diagnosed for something like this, like if you want, maybe you don't have access to good primary care, wherever you are or whatever, or you would like to have someone take a look at your movement mechanics. Is physical therapy something you can go to directly, or is this something that you have to go through a medical provider for? Like, after we're sort of done talking about all this stuff today, if people are like, I would like to talk to a specialist in this, because obviously in 90 minutes they're not going to now suddenly be able to do this themselves. How do they go about accessing that care, or even figuring out who a good practitioner in their area might be? Is there something they can turn to?
Yeah. So legislation varies from state to state. Most states have some form of direct access to physical therapy. So in most states, you can show up at your physical therapist and make an appointment and get seen. I am not up to date on which states are which at the moment.
Okay. Washington is one of them, I
Washington
guess,
is absolutely one of them. Some states are like, you can see a PT for 30 days as long as there's progress and all that stuff. Other states that I'm not sure about, they do require a doctor's referral, and if you have a good relationship with your primary care doc,
you can just ask them basically.
It's usually pretty easy depending on their relationship with you and how well they know you.
Okay.
There was a second part to that question.
Well, the second part of the question was sort of like, let's say that, and I guess this is sort of gets to the fact that if you're going to get help for something like this, obviously you may have preferences, or you may want to know that you're going to somebody, especially you mentioned there's many different systems of diagnosis, which is a question I wanted to ask you about later.
Yeah.
Is there some reading you can do, or a place you can go online to find out more about the physical therapists or other people who would do this sort of thing in your area, so that you can make an informed decision about who you go to? Because just like any medical care, not everyone is going to be the same kind of treatment. So I didn't know, is there like some kind of a resource you can use to find physical therapists in your area, or even if it was something, just a case of like, I want to go to, say I'm out of state and I like the way Emily diagnoses problems, I want to go to someone who follows that same school of this kind of, choice. Does that make sense?
Yes, it absolutely does. There are resources. There's the American Physical Therapy Association, and they have state chapters, and there's often listings of providers on their site. It tells you who's still involved in the national organization, but doesn't tell you much more about them. I certainly love the word of mouth network. If you really are lost and don't know where to go, often that's where a primary care provider can be a good resource as well. They're like, hey, I've heard good things about this person or that person, because they're in your local community. And no, a lot of the different kind of schools of thought may have their own referral bases and kind of lists on different networks. Mine does not. Though we do have our own spreadsheet that we have internally. So I can open up, if people are interested, they're welcome to email me, and I can see if I can make that available, and or possibly personally respond, depending on what the demand is. But yes, the school of thought that I was trained in is movement system impairments. So it's really looking at things on a movement-centric model. So some physical therapists practice a more joint-centric model. They'll look at the joint or the tissue that they believe to be injured and kind of work out from there. And I'm generally looking more movement and working kind of inward. And that is not necessarily unique to the school of thought that I am part of, but It's just kind of different mentalities to kind of get at the same problems.
So I sort of understand what you're saying, but I'm not totally clear. So you have like sort of a sub-network that you guys know about.
We have a Facebook group. It's really not that high
okay,
tech.
there we go.
I was just trying to figure it out. There is
Okay.
a document that is embedded into the
Okay, so basically, like there is sort of a professional. I guess it's not an organization technically, but a professional sort of network where people do know each other, but that's not necessarily exposed to the patient who just is generally browsing. But if people really wanted to,
if people are really interested
they could email you or talk to you at the. You can So let's move on to talking about the actual nitty-gritty here. So someone comes in with this kind of a problem, like something where it's going to probably be work-related, or maybe they don't come in with something that's work-related, but you suspect based on what you're seeing that it's going to be work-related. So what sorts of things do you start looking for? Like what is this kind of, when you just first start looking at someone, how they're moving? I know as someone who's gone through this process, like you do it very much like a software engineer actually would approach, a good software engineer would approach debugging a problem, where you kind of go like, okay, I'm going to start doing a bunch of testing and getting sort of information about what's going on. Can you just give us a little bit of introduction to like that process and what you're looking for, how you're putting those pieces together in sort of like maybe an abstract sense?
Sure. So when someone walks in the door, I have a systematic exam that I do. And it kind of almost doesn't matter what they walk in the door with. I'm going to do the same exam because it's going to help me pick up the bits and pieces that I may not have thought to check in the first place, the things that I don't know that I don't know.
Okay.
So by having a systematic exam, I run through everything and I can get a more global picture and kind of see how all the pieces fit together. So even if I do test 1 and 2 and I'm like, yeah, it's probably coming from this and that, I want to confirm it about 10 more times.
Okay.
So I really have a full exam that I do. So I start, almost always I have the person standing, I just look how they're standing. Before that, usually I'm talking to them in the office and we're taking a subjective, we're kind of getting an idea of what their problems are and all that. And what they don't know is I'm generally looking at them the entire time, looking at how they're sitting.
Okay.
But don't tell anyone I said that. Wait, hold on, I gotta do it too.
Yeah.
I'm not the best.
Please continue.
So I'm kind of doing a little sussing out before we even start. But my official start to my exam is in standing. And I look at their posture, just look how they're carrying their body and how they're holding themselves in space. And that indicates to me probably how they're doing it throughout their day to some degree. What's fascinating about specifically the shoulders, because I know probably most of you, if you do have pain, it's going to be more in the upper body unless it's low back pain, because a lot of people with sitting all day or standing desks now have stuff going on in the lower body, but I'll keep it to the upper body for the moment. But what's fascinating to me about the upper body and shoulders in particular is that they're not really attached to our body particularly well, which allows us to do cool things like spin our arms in circles. But if you think about the shoulder girdle, let's see if I can pull it up here.
Yes, we are trying an experimental thing here where we actually have an atlas of human anatomy. We can search.
Let's see. See how good we can get it here.
It picked it on this
did
page
pick
we're
it,
on,
picture it up.
but it probably can get
Yeah, I want just the
other diagrams. Too many scapulas, really.
There's so many scapulas. Let's see if I can do something better.
When I was looking through this atlas, I was kind of shocked at the number of details in the diagrams. I don't really like to think about my body as having all of these things inside it. So,
yeah. See if that was the best. That might. Okay, let's play with this because it's here.
Okay.
Okay, so.
You can draw
That's
on
right,
it
I can totally draw on
like
this. So can I point and not draw? No, okay. So this is the area I'm kind of talking about here. That is your scapula, this guy, this triangle, which is your wing sticking out on your back. This here, your collarbone in the front. In between those two sits your rib cage, so you can't like just poke and get your scapula. You have to reach back there. Uh-huh. But what's interesting is that you're only attached by a joint right here. And what that is at your sternum right there. And if you look at all of these bones and how heavy that arm is with all that muscle, that's the only little joint holding it up. That's probably not doing very much. So you've got this giant structure kind of pulling off your body, and what's holding it on is all the muscles, which is so very cool to me because it gives me so much information. So you've got this arm just hanging off the body, and just by looking at how someone's holding their arm, I can see what muscles might be stiffer or tighter, what muscles are longer or shorter, how they might move when they go to move their arm overhead, and all sorts of really neat stuff just by how they kind of hold their shoulder in space. It's my first test. Like, I'm not even having them do anything yet, I'm just having them stand there, but you can see so much because of how flexible this complex is, a shoulder girdle complex. So it's kind of cool. And there's something.
Can I ask a follow-up question there? I don't know if you want to keep going with that.
No,
I can wait till
please.
afterwards. Okay.
I can ramble all day.
Can you, which you are welcome to do, can you unpack a little bit, because one of the things you just mentioned there was sort of something that I didn't used to think about until having problems with this sort of thing, which is that I don't think everyone realizes necessarily that where their joints are by default has something to do with how their muscles have been used. Like, it's not necessarily that unusual when you say it, but it's just not something that I think ever crossed my mind. So could you maybe like give a little bit of background on how that works, like how muscles change how they situate things based on their use, or you know, I don't even really know how to ask the question because I'm not really sure I understand exactly how it works, but you know what I mean, right?
I do.
Okay.
It's a pretty complex question because to fully appreciate what's going on, you have to appreciate how much of it's going on. Like you were saying, you look at the stat list and you're like, there's so much stuff there.
Yes.
And so as you come to understand what all that stuff is and what all that stuff does, you can start to kind of see through the skin.
Okay.
You can start seeing like, oh, this shoulder is tipped forward a bit. So if the shoulder is tipped forward, what does that mean to me? What's going on the inside? Well, the structures in the front are going to be stiffer than the structures in the back.
What does that mean, stiffer than the structures in the back?
So stiffer means that you're probably using the muscle more. So it's probably stronger.
Okay.
And therefore, it's kind of winning this tug of war. So if you think of muscles as springs, which they contract and expand, so you can kind of get that analogy. If you think of muscles as springs, a muscle you use in a shortened position all the time. So if you're always using your bicep and it's always here, it's going to be stiffer relative to your tricep, and you're probably going to stand with your arm in a little bit more bent position. The shoulder's a bit more complex, so that's better.
So that's, okay, this is great. So when I'm moving, around, is that increased tension on the spring at its default position? Like, it's because we're basically saying like, okay, my rest state, this thing is now shorter, which means that my musculature moves to compensate it. The other muscles are longer than, I guess, essentially in their rest state. Is this a property of the muscle's size? Meaning, does that mean this muscle got shorter this way? Or is it a property of like the brain telling this to be this contracted at rest? Like who, do you know what I'm saying? Like, what is actually causing that shortness and the longness that puts it into a new position at rest?
So our bodies are really, really good at being efficient.
Okay.
So if we are constantly doing one thing or one pattern over and over and over again, our body likes to take shortcuts.
Okay.
So they're like, well, you always are bending that arm, so let's just keep that arm a little bent. We'll kind of just start there.
And that's neurological, meaning, or is that not a...
Yes.
Okay.
Just yes to all of it.
Okay.
It is neurological because your brain is telling your body to do these things.
Okay.
But then long term, and even relatively short term, like if you're sitting in a chair for like 4 hours a day, your body will start to make changes.
Okay.
Your body will start to lay down different tissue structure in your muscles to help support, so they don't have to constantly send that signal to fire, 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 fire. Thankfully, as we stand back up again, our body will change that tissue back to good contractile muscle tissue. Our bodies are highly adaptable and super, super efficient. So yes, it is neurological, saying yes, fire that muscle. It is also physiological in that our muscles, when they contract, we kind of have these two things sliding over each other, and that's how they shorten. And they've got these little oars, and they kind of pull. It's very, very cool that it happens so fast. But instead of kind of hanging out here, they'll start hanging out here. Because again, it's more efficient because they know you're going to bend it again to go there.
Okay.
And so if you're not ever using that range of the muscle. It's not going to be as available. But as I said with standing up after sitting all day at work, it's highly changeable. So if you start, in this particular example, using your tricep and fully extending your arm and not working in that shortened position all the time, it changes.
So essentially, I guess, does it break down into very short-term or short-term and long-term effects in that sense, meaning pretty quickly my muscles will actually pick up new neurological starting points, basically, like over, not too long they'll maybe do this thing, whereas it sounds like you're sort of saying once I get them into that sort of rest position, they may actually start to change their shape eventually, or does that never happen? Is it always neurological?
That will eventually happen, but usually you're casted. Like you're there long term.
Okay, so it's mostly just the actual mental, where am I keeping this muscle?
Yeah, it's mental. It's also the strength of the muscle. So because you get stronger, so you're getting that passive spring gets stiffer and thicker.
Okay.
And the other spring is kind of this flimsy, loose spring. And so at rest, you've got a tighter spring pulling this way than you've got pulling that way.
So a stronger muscle in the sense of literally like a bodybuilder stronger muscle, like I'm building muscle. When the muscle builds up, it becomes tenser by default. It's not
at rest. If we're just talking at rest. So if you are always doing biceps, and which essentially if you stand like this all day long you are doing, but if you're always doing bicep curls, for example, and you're never doing anything for your tricep, you will just have a stiffer bicep spring than your tricep spring.
So it doesn't, when a muscle necessarily, even when you're talking about building muscle that has nothing to do with like the physical therapy aspects or the pain aspects of it, if you're just building muscle normally, at that point, it's not just that the muscle's capacity to pull when it wants to pull is more. It's sort of, in some sense, always pulling. So if it gets stronger, its base level of pull is just going to get stronger. That's just how it doesn't.
Yes, but ideally everything's getting stronger together.
So you're trying. That's why.
You don't, going in and doing like one exercise is probably not the best bet. Global exercise is really a lovely thing.
Okay.
Yeah, keeping that balance, because our bodies like balance. They are built on a system of balance. We think chemically, our bodies want to be in homeostasis. We don't want. If you eat, I don't know, a ton of acidic foods, for example, your body will not become more acidic because our bodies always want balance. And the same thing's true for our muscles. Our muscles want to keep the same length on this side, or the same tension on this side as this side, so they get a nice even pull. And that's how everything kind of stays happy and healthy.
So let's go back to the shoulder example then, because I think that, sorry, I just wanted to unpack all that stuff so we could sort of start out with me knowing roughly what's going on with the shoulder strength. So, okay, so back to the shoulder example. Somebody has their shoulder and you can kind of see that it's, in an unusual position. So that, positional information is sort of now telling you, okay, now I have some information about how the default rest, tension on each of these muscle groups is, and I can see that it's a little wrong, meaning one of them is too tense at rest, and that could be causing problems. Why? So why did it start to cause? Let's get into this. What are problems at this point? Because now we've got
I'm kind of going to rephrase what you said a little bit.
Oh, please do. Yes.
It's not that passive resting tension that causes problems. It's the things that you're doing that's causing that passive resting tension.
Okay.
So I'm going to kind of go around the circle, and we're going to.
Yes.
Yeah. So I found that I saw this neat little thing. So this is the shoulder from the back. So you've got your arm bone here, and that's the eraser. That's not going to work. The arm bone here, and the shoulder blade here. And to bring an arm up overhead, for example, the first 30 degrees of your arm motion is just the humerus spinning in the socket, so just that arm bone moving out to the side, about 30 degrees. And then as that goes up overhead, you get a 2-to-1 ratio of 2 degrees of the humerus moving for every 1 degree of the shoulder blade moving as well. And that all has to work together. And if it doesn't work together, that's when you can get pain or problems at the shoulder joint, at the neck, even down the arm, depending on kind of where you're predisposed to kind of get those issues. But as that arm goes overhead, so if you guys are feeling bold and you want to not hit the person next to you, take your arm up in front of you and bring it up overhead, you should feel your shoulder blade coming almost underneath your armpit. This is awesome. Super awesome. But you should feel your arm kind of spin and then your shoulder blades spin around your back and come up. So someone who walks in and their shoulder's already kind of tipped forward, and it can be just tipped forward, or it can be rotated around the outside, or it can be lots of different things depending on how they're moving. That spin, roll, and glide of all those joints moving together is not going to happen as well. So they're going to show that in pretty much all their movements, or a lot of their movements, probably especially when they're in a position that they have pain in. So that's kind of what I'm seeing when I'm seeing, something like this. It's like, okay, well, that's going to tell me that they're doing something else that's strange, or they're just sitting all day like this, and they're never coming back up. So that I'm going to see and find that their back muscles aren't as strong, because what makes that shoulder blade go around is 3 different muscles. You've got your upper trapezius up there, your lower trapezius going down that way, and your serratus anterior, which is my favorite muscle right now, going that way.
I'm sorry, right now?
It changes.
Okay. Do you have like a muscle of the month club or something?
No, it's probably like in every 6 months or so.
Okay.
It kind of goes with the wind. I don't know.
That would be a nice webpage, the Muscle of the Month
Muscle of the
Club,
Month
where
Club.
you could go and read about this muscle.
It's actually not about
It's not. I would subscribe to this newsletter. Sorry, continue.
No, it's cool. So you've kind of got 3 directions of pull. You've got kind of an up, and because it attaches on this corner, it's going to pull it around a little bit. And then you've got a down, and again, because it attaches on this corner, it's going to pull it down and around a bit. And you've got a forward and, again, up, and it's going to pull it that way. So that pulls that shoulder blade into that upward rotation. So now if you've got this forward shoulder thing, because you're sitting there typing all day, a lot of times the back musculature isn't quite doing its job. So the muscles back here, like the trapezius. And sometimes even the serratus here isn't doing its job, because serratus pulls the shoulder blade forward and up, but the thing that pulls the shoulder forward and down is your pec muscle in the front. We all pretty much know what a pec muscle is, I'm assuming, which is fighting it. So sometimes that guy turns off because he's like, well, shoulder blade's already getting pulled forward. I'm going on vacation. Because again, bodies are efficient.
So it just already knows it's there, so the brain is not trying to move it
like
anymore.
It's already
so
forward.
kind of
I've already found a way to do that.
Yeah,
So now I'm
we're
just
done.
going to do this weird other thing when I go to raise my arm up above my head.
Okay.
It's not quite that bad, but when you look at it all day long, you start to see these things pretty clearly. So it's not necessarily the resting position that's doing it. It's maybe the active position of typing all day, or the active motion of doing this all day, which I don't know why you would do, but I mean, maybe if your career is different and you're doing more of a reaching task, or you're mousing, but you're like mousing like this for some bizarre reason.
Which actually isn't probably that unusual for, say, if
Probably
the
not
desk
that
was too
unusual.
high.
Yeah,
or something, right?
if you've got that,
Yeah.
it's pretty common. So there's lots of different ways to kind of create weird postures that will do weird things to you.
I wanted to ask, sorry, I'm pointing at this.
Yeah,
instead
no,
of
it's
that,
fun because it looks really cool up there.
It does kind of look cool up there. I like the muscle drawing too with the strands. I was like, oh, that's pretty cool. So you were talking about sort of the movement ratios there. So essentially your brain has to sort of contract these at resolved rates. Like it's like this one has to contract twice as fast as this one to move this into position, and then I've got, so the sort of the function that we're looking at here is kind of this like piecewise thing. It's only one of them is going, then it's a 2-to-1 ratio of 2 of them, and then another one might kick in. This is right.
Well, yeah, I mean the 2-to-1 ratio is to the end of the range.
To the end of the range.
So you end up with 180 degrees total, 120 degrees of arm motion, 60 degrees of scapular motion.
And so
It's just engineering.
is that process part of? I don't want to call it an impairment because that's probably the wrong term.
That is the term I would probably use. I'd use a movement impairment.
Movement impairment,
Yeah.
okay. So if you are having a movement impairment, are we talking primarily about that sort of muscle rest situation that you sort of were describing that I'm getting a better handle on now, but probably still don't quite get exactly? Is that function, is the brain's series of things that it's firing and how it's firing, is that also implicated sometimes, all the time, et cetera? So meaning it could be that the muscles at rest even are okay, but your brain's function for moving them is wrong, and so now instead of 2-to-1, it's 3-to-1, or instead of 2-to-1, it kicks in at the wrong time. Can you like?
Yeah. So
I mean, we may not know all this stuff, but I mean, what we do know. I mean.
Yeah. So sometimes somebody walks in the door and their movement and their standing posture is totally normal. Again, we only got to the first part of the exam. We got to standing, and then we got sidetracked. So, which is great. But this is what I do next. Is then I look at how they move their arm for an upper body exam. So. Sometimes people walk in with completely normal posture, but they don't have the right neuromuscular coordination to make the movements happen at the right time in the right place. Sometimes, everything fits and you see it all together, but usually it's not the resting posture that's causational. It's a symptom. It is a part of the entire sequelae of symptoms that they see or patterns.
What's the word you just used?
Sequelae.
What does that mean?
SEQUA.
Okay, is that just a term? Is this a regular word I don't know? Or
I use it. It's a grouping of symptoms.
Okay.
A group,
got it.
Yeah.
Thank you. Sorry to interrupt.
The gestalt of the movement impairment. So yes, the resting posture is almost never the cause. The resting posture is occurring because of how the person is moving in their daily life.
Okay.
I think that was what you asked.
Yeah, well, I guess if we sort of go further into the second part of the exam thing. So when you are, starting to ask, I mean, because a lot of times that exam is sort of like, try doing this, or you will sort of position the person, right? You'll like put them into a position and you'll ask them to like push or pull or something like this. Can you talk a little bit about that, like what that's checking for, how those sorts of things go? Or is that the best thing to talk about next, or would you rather talk about like nerves and stuff first? I don't know which one's going to be better for you.
I can go either way. I'm happy to continue going with
Let's talk about the second part of the exam part then, because sort of, now that we know what's implicated,
So once I'm done looking at somebody standing still, I'm going to watch how they move. So I have them do basic movements like bring your arms up, bring your arms down, bring your arms out, rotate your arms. And if any of those cause pain, I want to see if I can then eliminate their pain by grabbing a hold, say, of the shoulder blade and moving it where I want it to go, and see if that eliminates their symptoms, because that gives me a ton of information. Oh, you have pain when you do it. Well, when I do it for you in theoretically a better pattern, is it less painful? Does it change how your symptoms are occurring? I will then have them do things in different positions. I will test the strength of muscles. And when I test the strength of muscles, I'm looking for a couple different things. I'm looking for, okay, sure, is the muscle strong? Is it strong enough to do its job? But that's not the primary thing I'm looking for. What I'm actually looking for is, are you actually using the muscle I'm telling you to use? If I put you into the position that is optimal to make that muscle fire and you're using everything else, it's telling me a lot about how you're moving throughout your day. So I'm like, okay, use this muscle exactly. And then and I'm like, pull your shoulder back. And you go, well, that's not right. So I'm looking for how you choose to hold the position with the muscle. And then if your position is good and you're firing the muscle properly, if I resist that, do you still continue to use that muscle to do it, and how strong is it? Or do you then cheat and use something else secondarily?
I see.
And I kind of do that in all different positions of the body, through lots of different movements of the body. And I'm really just looking for what your patterns are and how you choose to cheat the world around you a little bit, which may or may not be leading to your symptoms or your pain.
So one of the things that kind of I noticed in relationship to that sort of thing, like the positioning and having someone use a muscle in particular, is that it seems like sometimes, at least for me, and I don't know if this is generally true for people more broadly, there are muscles that you can't really even target with your brain until you've practiced. Like, I don't know how to say it any other way, but it's like, sometimes it's like, oh, okay, pull your shoulder blade back in this way or something, and I'm like, I don't know how to do that, right? And it's like, maybe that muscle is normally firing as part of some other thing that I think to do, but it's like, I can't think to contract just that muscle. And then I have noticed that over time, then your brain does sort of learn to be able to maybe target that muscle more specifically. Am I totally misinterpreting that, or is that a really a thing?
It's a real thing.
Okay,
your
can
brain,
you explain that a little bit? Yeah.
Your brain and your neurological system are again, very, very changeable, very adaptable. And some people have kind of an innate idea of where their body is. Some people don't. Some people can learn it. Some people it takes longer, but they can learn it eventually. So during my exam, for example, I'll often place someone where I want them and then say, hold this, because I want to know what they're going to hold it with.
Okay.
But there's ways of tricking the brain into kind of finding that muscle. You can tap on the muscle.
Oh, really?
And that kind of helps stimulate the nerves a little bit. You can use different visualizations. You can try to equate it to a movement that they're already familiar with. Like, oh, it feels like when you do X, Y, Z. Yeah. So there are ways of doing it, but the brain can learn to fire anything or fire anything in a new pattern. It just, for some people, it comes a little bit more easily. For some people, it's a little harder. And you can try a million different ways of telling them, showing them, hands-on moving them, so many different ways of cueing, or we call it cueing, movement and patterns and muscles to actually fire.
So I think that's pretty good for the basics of, well, I guess there's one thing we had listed on here that we should probably talk about, because I'm going to start talking, moving on to sort of like the actual pain part, like what's causing that or how that's
Sure.
working. But one thing that you had mentioned that I actually don't think I know anything about, because I don't think you've ever mentioned it to me just in the course of like actually doing physical therapy, spinal alignment and plumb line you mentioned, which I'm assuming is about the thing that am doing wrong right now or whatever in the sitting, but like what did you want to say about that?
Yeah, so if you think about your body, most of us think about kind of being anchored to the ground, either through our feet or right now through our butts on our chairs. But most of our movement and all our musculature is anchored from kind of the center out, because every muscle has at least two ends. So again, we'll use the bicep as an example because it's easy and relatable. It attaches at your elbow and it attaches up at your shoulder. So if you're not able to stabilize the shoulder end well, you'll never be able to fire at the elbow well. So this is proper biceps firing-ish. And then improper biceps firing, you'd have a wiggly shoulder because it's yanking and the muscle's shortening and does not have an anchor. So if you don't have a properly aligned spine, you're not going to be able to fire everything else as well. The spine does not always have to be in its perfect neutral alignment all the time. Our bodies, again, are highly adaptable. We are able to move it in all sorts of different ways and directions, but having a neutral spine or a neutral spinal alignment can really help you kind of get a handle on what else is going on in the body. So the spine is an S-curve. Let's see if I can find a picture of the spine. I had trouble finding it before, but we'll see if we can get it to pop up. No, that was the problem. The problem is that bones have spines, and like little outcropping of bone is also a spine. So when I get like a lot of spine, no, they will not. But we can try cervical spine, for example. Let's see.
It's thinking.
It is thinking. They did not find. They do not have a cervical spine.
We didn't find any result.
No.
That was very like it wanted to include us in the failure.
None of us.
It didn't want like it to be responsible for it. It wanted all of us to be responsible for it.
Ooh, if I could spell properly. Let's try thoracic. So your spine is broken up into three different parts. You've got your cervical, which is your neck, your thoracic, which is your torso, which all your ribs attach to.
It might be in the second PDF if you really need it. There were two volumes of this, and they're both on there.
Okay.
How bad do you want to have a spine diagram?
I'll talk about it, and then if we get enough hooting and hollering or something, we can look at it.
Okay.
Cervical spine is the neck. Thoracic spine attaches the rib cage. Lumbar spine, low back. And a spine should look like, let's see if I can just find a pretty blank page. Should I erase all my little notes here?
No, they're good.
Sure. We'll use this space because it's relatively clear. Excuse me. So cervical spine, let's see if I can do this. Thoracic spine, lumbar spine, sort of. Cervical spine, thoracic spine, lumbar spine. Ish. It's curvy. The skull is here. So your spine acts a little bit like a spring, and it absorbs energy kind of as we walk and move throughout our day. But this alignment is kind of important because, and this is true in sitting or in standing, and the plumb line I was discussing drops basically from the ear down the body, and it's about like how much of your body's in front or behind, and it should be about half, and what things are you cheating or compensating with. There's some really neat different examples of poor posture. If you just look up spinal alignment and you Google it, it'll show you like arrays of posture, like if you're leaning back or leaning forward or all sorts of things. But let's use sitting, because I'm sitting and we're here. But if you're sitting, and let's say it's the end of a long day and you're like this, not only have you changed your spinal posture, my shoulders have rounded and come forward, and now my head's gone forward. Now my neck musculature here is going to be tighter, my neck musculature here is going to be tighter. This is going to influence how my nerves are coming out of my neck. See how we're segueing into nerves there? Great. And down your arms and into your hands. Or maybe at the end of the day, you're more like this and you're typing like that. I see this one a lot. Again, your lumbar spine may or may not be that bad. It may also be curved. But your spine's kind of taking on this C shape. Your shoulder blades are moving up and around your back. Your shoulders are again forward. Your arms are internally rotated. So really, how you're sitting makes a big difference on all the structures throughout your body. So that was kind of a long way of getting to the point of, like, hey, know what you're doing and change positions frequently.
So let's talk about one thing that you said there that I totally forgot about when we were talking about the shoulder, actually. The stabilization part of it is kind of interesting. Like, I had not thought about this previously until you had explained it to me, actually, which is that I typically think of, for some reason, because having done character animation for a living for 5 years, you'd think that I would have thought about this before, but I didn't. Or maybe it's because of that. I tended to think of muscles in isolation, meaning even if I was thinking like, oh, this group of muscles is doing something, I neglected to think about the fact that whatever they're doing, muscles upstream from them are going to have to counter. Because if they didn't do that, it would pull the rest of you into wherever that muscle was going or away from it or something. So can you just cement that? You mentioned the stabilization part. I was like, actually, like, wait a minute. Many people may not actually have internalized this because, especially for in computer graphics, we don't have this. Like, we just move the thing and it moves. We don't have to think about the ripple effects.
Oh, yeah.
So can you just talk a little bit about that?
Sure. For fun, everybody reach your arm out in front of you and make a tight fist. And see if you can feel what's going on at your shoulder blade behind you. And then open your hand, make a tight fist again. And you should feel the muscles around your shoulder blade contracting in the back, which is just so cool that our bodies just do that naturally. But every muscle, when it fires, like if you look at a picture of a muscle and you see like the stripes, kind of like I was drawing on the overhead there. When you see those stripes, those are the angles of like the lines on which the muscle contracts, which means it's contracting on both sides. So it's not just contracting and pulling the arm up, it's pulling on both sides, which means every time you have a muscle firing here, you have a muscle pulling on the other side back the other direction. Specifically for the shoulder blade and why the serratus anterior is currently my favorite muscle, is I love to think about how the shoulder blade is stabilized because it is just so neat. Like I was saying before, the arm is a really heavy structure. You've got all those bones and those muscles just dangling off that shoulder blade, pulling the arm down and out away from the body. So if that's all pulling this way, you need to have muscles pulling this way. But to counter that, you need to have a muscle pulling this way. And most importantly, because that arm is pulling downward, because it's only attached at the top of the shoulder blade here. I feel like, oh, we lost it. Okay. Since the arm is only attached to the top of the shoulder blade here, you've got this whole rest of the triangle. It's going to pull the arm just from the weight of it in that downward rotation. See, now I'm just making a mess. Let's see. So this arm bone here is only attached at the top corner of the triangle, which means just at rest, just hanging, if no other forces were present, you'd have this downward pull of the scapula into downward rotation. So you need your middle trapezius to be pulling in against that outward force. Your lower trapezius is going to pull into a little bit of the upward rotation like we talked about before. And your serratus anterior, which is going to pull in outward and into a little bit of that upward rotation. So you've got this counter pulling going on. You've got an in pull, an out pull, and they're both helping it upwardly rotate against that arm, and that's just at rest. So every time you then go to move that arm, everybody's kind of got to recalibrate exactly how much energy they're putting where. That same thing is happening. Okay, now I'm going to flex the elbow, and I'm going to bring that up. Okay, I've got the biceps pulling here, so I need to stabilize more with this pull here as this pulls the arm up there, and now I'm just creating a giant mess on the board. But
well, actually, that's really fascinating because it's essentially like, well, we have this, rigid body dynamics problem basically where we've got this thing there. We've got points that we're pulling on which will induce torque as well as linear motion, and it all has to balance out properly. You only can exert certain directions on it, right? Because
I'm simplifying things. There's also tilt and
yeah,
and there's lots of different muscles that correspond to that. But yes, you are slightly limited, but you have quite a lot of options.
So it sounds like too, I mean, just from the physics of it, that means that essentially when I'm sitting or standing or anything else, the contact points with the rest of the world are essentially where all the energy has to flow back to in some sense. Meaning whatever I do, all the muscles up to the point where I'm grounded have to be involved. Otherwise I would, the inertia, I guess, takes something out of it over the course of
This is where I'll challenge you to now think about an aerialist in space. If you take my circus performer, they do not need a grounded contact with the outside world. They just need their core and their spine and all their stabilizer muscles to be doing their job. So it's not necessarily about the contact points on your chair or in your standing. It's about how it interacts with your stability internally.
But so does that mean that the body is just heavy enough on its own that we don't really have to care about that external contact? Because even an aerialist, they will change their whole body's orientation as a result of those motions, though, right? Meaning, do you know what I mean? Like, so it all ends up, it's a zero-sum game, I guess is what I'm saying, or something, I'm not sure.
I mean, physics still applies.
Yes. Okay. So does that mean, just trying to get to the whether those are important or not, if you are standing, does the series of muscles that are involved in, say, moving your shoulder, when you consider all the contractions, no matter how tiny that would happen, are they different because they can stop at your tailbone than when I'm sitting, than when I'm standing, when they cannot stop at my tailbone because they have to go all the way down to my leg before they hit solid support?
They still don't stop at your tailbone even in sitting.
Okay, so your legs are still counterbalancing.
Your legs are still involved
Okay.
in some way. So like when I was sitting just now with my legs crossed, I'm exerting a force probably inward a little bit. There's a little bit of outward force that's crossed, and I'm getting stability from all of that in addition to what's going on at my core. So it doesn't stop kind of at your sits bones. It really does translate all the way down. It does change a bit when you're standing because it changes your leg position, changes where you're exerting forces, but any little motion you're doing is somehow affecting everything. Ideally, your core is kind of a transition point. You'll still get some effect up and down, but your core is kind of should be one of your most stable structures.
I see. So that's like the place where a lot of the energy kind of dissipates by that point. We've gotten to people don't have to do too much contraction or
right, which
relaxing.
is why when you're sitting, you're not really feeling your legs do much. They're active, but they're not really noticeably active. Yeah.
Okay, that is a lot to digest, but we've got a whole bunch of stuff to go through here. So let's start talking about the actual those are sort of the cause of the problem, perhaps you might say, in terms of like what you're doing that's making the problem happen. But the problem you're actually feeling ends up being something nerve-related or blood flow-related or something like this. Can you start to give us an introduction into like that? It's like, I'm having pain. What does pain mean? Like, there's different ways in which that might manifest itself or discomfort, right? Can you just start giving us the intro of like, what's that part of it about and where is that coming from?
Okay. Well, there's a whole conversation about what is pain, but that could be a whole nother hour or two. But it is really a creation of the brain to sensation that it doesn't quite understand. So pain is kind of a vague, overarching catch-all for most of the public, but I really kind of break it down to a couple of different types of pain. Numbness, burning, tingling, those are going to be your nerve symptoms and usually are coming from a neurological source. Whether a nerve is being compressed, a nerve is being pulled, that's usually going to be a nerve symptom. Dull achiness is often muscular pain. When it's more of a spasm, can be a little bit more sharp, a little bit more acute. but you've got different kind of categories and qualifications of pain that you're feeling. And that can really manifest anywhere in the body. As we're talking, the causes of all that, even if you have, say, your pain or nerve symptoms in your hand, it could be because of what you're doing at your shoulder and kind of how that's translating down or translating back up. And it's really quite a broad topic.
Okay. I can sort of focus it in for you because I've got a bunch of questions.
Yeah, great.
So, all right. So you sort of listed, I think, 5 things there, basically. Three. Right? You said numbness, burning, tingling.
Yep.
Right, and then you said aching or
dull, sharp,
and then sharp.
pain. Yeah.
So all of those, I guess, are. I mean, the brain doesn't get information back from muscles directly, right? It only gets information back from the nerves, I assume. Meaning all of these are traveling on the nerves?
Yes, all of these are traveling on the nerves.
Okay. So can you, and some of these maybe, I mean, obviously, some of these are more neurologist questions, so please, if I'm going outside of the discipline, I apologize. You can just tell me.
Sorry,
like,
I probably should know it somewhere back in my
yeah,
graduate
it's like
school days.
right. It's like someone asking me about some programming language I haven't seen in many, many years. But can you give us any sort of understanding of like those things? Do they indicate a particular thing that's happening with the nerve that we understand? Meaning that medical science kind of knows like, oh, right, when you're seeing tingling, that means the nerve has had X happen to it somewhere along the line. If you're experiencing a dull ache, that means the nerve is picking up this. Like, what is happening there? Do we know or do we not?
The tingling or numbness is usually neurological compression. It means the signal is not getting through clearly.
Okay.
So it's kind
signal
of...
meaning electricity flowing along the wire, essentially.
The wire, yes.
Okay.
The information that is being transmitted along the neuron, because that's where our information highway of our body is not getting through clearly. So numbness is nothing's getting through. You can't feel anything because there's nobody's traveling.
So that's a complete break for some reason. Either it was cut or compressed or something has
and it could be anything. It could be I was just laying on it. That's why if you're laying on your arm, something falls asleep. You go from that numbness to that tingling to that burning, and then it goes back to normal. So like you can have it even on that minor scale, and that kind of is what that nerve pain is. So
so those are all actually essentially the same thing, just a different
spectrum.
amount. So it's like how much electricity was able to travel through, or not how much electricity, but how
signal,
is where you are on that line. Is that correct?
Kind of, yes.
Okay.
And everyone will kind of experience it a little bit differently, but that's kind of the general scope.
And then what about the other ones that you said, okay, this is the nerve is functioning fine, meaning the information's flowing, back to the source in the amount that it's supposed to, but I'm still getting pain. How is it picking up, like what is the dull aching or the muscle spasm pain? Is that something the nerve is sensing, or like how does that, or is that
That's
neurological?
a really good question. Okay. No, it's a good question, and
Okay.
it's a very big question.
Oh, okay.
It is one that is currently being studied more and more, but we do know a lot about pain. Pain and that dull, achy feeling is how our brain is translating that it's trying to figure out what's going on.
Okay.
Kind of there. So it's not the muscle that really feels that way. It's your brain trying to make sense of what's going on there. So it's a constant contraction, say, at the muscle because it's a spasm, and your brain's trying to figure out how to interpret that signal.
And so the signals that it's getting, this is me completely making something up, so this may be very wrong. When you say it tries to figure out what's going on, is that in a sense saying, well, okay, I've got these nerves that are going out to various parts of my body. My brain is used to the signals coming back this way. All of a sudden, I see that they're coming back differently from this, and I'm worried, so now I am just your brain's way of saying, I don't see the right signals coming back is dull ache or something else.
Or some sort of pain.
Okay.
Yes, we only have certain types of receptors for sensation in the body.
Okay.
So we don't have like, I feel water bottle. You feel cold, you feel hot. Oh, sorry, you feel hot but not cold.
Oh, really?
So the absence of feeling hot, you feel as cold. So like things like that are it's pretty binary. Like we don't have as much sensation we interpret sensation more broadly than we actually sense it.
Okay. So the brain is filling in a number of gaps
Yes.
here.
Yes.
And I suppose that is probably why these sorts of things are difficult in the diagnosis phase, because it's like, well, it's such a blunt, the information the patient can give you about what they're feeling is really kind of fuzzy, because their brain is just sort of looking at some not particularly great signals and just producing an output. And it's like, well, we can try to figure out what that means by how we've seen it happen in the past, but it's just not really as precise as we would like to know.
And some people are just better at verbalizing than what they're feeling, because it's also an interpretation problem of,
Right.
okay, I can feel it, I know what I'm feeling, but how do I
Say it.
spit that out in words? And then, honestly, I don't find people's ability or inability to describe their symptoms that limiting diagnostically.
Okay.
Because I'm looking, again, for all these other indicators. So if you're saying, I have weirdness when I do this thing, that's usually enough.
Okay, so you just any indication that the brain did something is probably like, okay, that's the clue I need, and now
it's weird enough that you've come into my office.
Yeah, that's good enough.
That's good enough.
Okay.
I don't really need somebody generally to describe that much further, other than, I think it's more this or that. But it's usually how they're moving that I'm looking at more than what they're saying.
I don't have this written down, but I meant to write it down, and since I'm thinking of it now, I'm just going to say it. So can you also briefly just mention or discuss referred pain, to the extent that we would need to know it for the stuff we're going to talk about here? Like the idea that the pain maybe is misplaced in terms of where the patient thinks it's coming from.
Yeah, so there's different types of referred pain, and this is a great place to say something that I'll get to in a second, because it doesn't matter yet. Different types of referred pain. So usually referred pain is symptoms you're feeling that are not from the place that you are having an issue. So on a simple musculoskeletal level, something that I deal with almost on a daily basis is if you have pain in a straight line here at your shoulder, it's your rotator cuff.
Which is
the deep muscles of the shoulder that actually control the spin and glide of the actual humerus. They don't run in a vertical line on your shoulder, but that's where you feel it. On a more global medical scale, you can have pain referred from your organs and to somewhere external on your body in the myotomes, meaning on the skin. And that may or may not be actually musculoskeletal. You can have pain from the inside of your body expressing on the outside, and that's kind of what I want to talk about, which was musculoskeletal pain, including neurological pain, tends to change with position. It tends to change with time of day or activity or what you're doing. Pain that does not go away no matter what you do, you're going to want to get checked out probably by your primary care doctor first, because there might be something else going on.
So even if it appears to be in a location that would suggest that it couldn't be something like an internal organ, that may not be true at all.
It may not be true.
It may be that it's actually something that has nothing to do with your body mechanics.
Yeah, for example, like a gallbladder will refer pain to like the back. And people will come in with back pain and be like, ow, it hurts all the time. Whenever I do, I can't get it to go away. And I'm like, that's probably not your back. But I mean, you could have...
Good news is your back is fine. The bad news is you need to go see someone about your gallbladder.
Well, I mean, you might have back pain all the time, but it should at least change intensity. There should be things you can do to mitigate the symptoms.
I see.
So it's just an indicator to me that there might not be a musculoskeletal thing going on. There might still be, but it's worth checking out. Usually there's other red flag indicators or things like that that make my little ears perk up, but it's just another thing to think about.
So I guess let's, since we've kind of gotten, I think, most of the things, well, actually, we did not talk about vascular things at all. And part of that is, I think, because I don't actually know anything about these. I don't think I've ever heard you mention them to me either. So could you just tell us to what degree that's important for these sorts of ailments, and what we should be aware about, or what we should be aware of in terms of those pathways, yes, arteries and veins and things?
I'm going to just take this where I want it to go. So let me see if I can find a picture that I might want. Let's see if this has that on there. No. Well, hold on.
We could bring up the second PDF, which maybe has some of the spine stuff on it. I don't know if they were separated in the book. I grabbed the one that's upper limbs and stuff, and then I have the other one. Do you want me to bring it up?
Well, let's see if I can try something else here, because I think I saw something good with it before with the scalene. So let's see. Look at all that beautiful vascular bundles. That's not bad, but not if you don't know what you're looking at. That's kind of cool. Okay. So this is somebody from the side. The shoulder's been removed, so the striped things that you're looking at here are the ribs that look like ribs. What else has been removed? So if you see this little white disc here, that's where your collarbone attaches. Okay? So your collarbone would sit right here. Blue in this case means vein, red means artery, yellow here in this block are your nerves coming out from your neck. So here you've got your collarbone. Here you've got your veins. They're going to come down around, go down your arm that way. Your artery's going to go down around, down your arm that way. Technically your artery's going down your arm, your veins coming back up. And your nerves are going to come out and go down that way too. So everybody's now passing under this collarbone. So your nerves are passing under, your arteries are passing under. So sometimes what people are feeling as nerve pain or muscle pain is the fact that they're not getting the blood flow to the muscle or to the nerve that you need for things to process properly or to function properly, because you need those nutrients flowing, you need oxygen going to the muscles to produce contractions. So everything comes out here. So you've got, what I pulled up was the scalenes. So you've got these muscles that come across the nerve. See these nerves coming out there and coming across the artery. Let's see if I can get a better picture of it even. Ooh, yeah, see, that's cool. Again, the yellow is the nerve, the red is the artery coming out. And you can see the scalene or the muscle of the neck there coming up, crossing over all of it. And then you've got the collarbone that would be, all of that's been removed, but that would be coming out here across it as well. So this just kind of shows you how intricate and how integral your posture and movement are. Because if your head's doing this, you've now tightened your scalene muscle, which is the guy I just drew in. He's now tighter, trying to hold your head up and trying to figure it all out, which can put pressure on your nerves and arteries. If your shoulders are kind of depressed and hanging out because you're down here and your arms are kind of hanging and you're using your laptop on your lap kind of thing, now your collarbone has been depressed and is pushing down on your nerves and arteries. And that can lead to you having symptoms way down in your hand that you didn't realize was because you sit like that, or something like that. So that's kind of what I think is really important about your blood flow, is that it can really cause all sorts of symptoms, because if you're not getting the nutrients you need out to the periphery of the body, you're not going to be able to function properly.
And is that sort of a property just of the fact that the further something is away, like essentially whatever the body is trying to carry out to its systems deplenishes as it goes out. So if I start to reduce the flow, it means the furthest out things are the ones that get the least of it, or is that an incorrect characterization?
You know, that I haven't thought about it that way,
Okay.
but that's probably pretty good.
Okay.
There's also the chance that multiple things can go wrong. So if, your head is doing something weird, which puts more tension on your neck muscles, and then your shoulder's doing something weird, which puts more tension on the structures themselves, and then you're not stabilizing properly, so you've got something going on at the elbow because you're overworking your forearm musculature, and now that's working too hard because it's trying to stabilize your elbow and move your hand, and then you come down and you've got the narrowing at the wrist, and you get to your fingers. So there's lots of different places where things can be less perfect.
Is that, I've heard you use the word double crush before.
Yeah.
Is that what that is?
That is the idea behind double crush.
Okay.
But double crush just means there's something going on up here and something going down
Okay.
here. But really, it could be an incy bit here, an incy bit there, a teeny tiny bit there, and a little there, and you end up with something.
Quadruple crush.
A quadruple splish,
All right.
or whatever. Crush,
Okay.
I think, is just so dramatic.
Yeah, it does sound a bit dramatic. Okay, so I think that's all of the I think that's all of the stuff for just like basics of the functioning, so we can get into some of these, because we've got about 20 minutes left. So I just wanted to kind of go through like I wanted to go through some of these ones that you had down here, and maybe we can pick which ones are probably the most important, or maybe you can just kind of touch on each one briefly so people know about them. You sent me a list of common ailments that people who sit like this all day might get. And the first one was medial or lateral epicondylosis. Am I pronouncing this correctly? Okay.
Basically, it's pain at the inside or the outside of the elbow. We used to call it epicondylitis or tennis elbow or golfer's elbow, or probably terms you're more familiar with. We're just moving to the osis because it's more accurate. Itis meaning inflammation of what's going on there. Osis meaning mini tearing. Well, tearing, but mini tearing. It's not things flying apart. Basically, it means you're overusing the things in your forearms. You're either overusing your finger flexors. If you make that tight fist again, you'll feel everything tighten up by the inside of the elbow. And if you pull your fingers back, you'll feel everything tighten up by the outside of your elbow. And so if you're using that a lot and not stabilizing properly up the chain, I call that up the chain, back towards the center, you are now asking those muscles to do a ton of work, and they would probably be better served with better support up here so they don't have to work as hard down at the finger level. I find it is common with trackpad.
Oh, really?
Sometimes. I
like
mean, it can be
the kind on the laptop.
Yeah, so you're doing like a swiping motion a lot, so you're doing a lot of finger flexion, and you're probably resting your arm somewhere, or doing something weird, and not supporting, or again, this one.
Right. So carpal tunnel syndrome was the next one, and then you said it had a parenthetical that was and other nerve issues.
And other nerve issues.
I'm not sure what that means, but
well, I know because I've heard most of this from Casey. So when people walk in my door, they may or may not. They might say something like, "Oh, I think I have some carpal tunnel," or they might say something like that. But usually it's either self-diagnosed or not diagnosed, and you've said like, "Oh, everyone thinks they have carpal tunnel."
They do, yes.
And it's kind of like, well, I wanted to kind of say, this is what carpal tunnel is.
Okay.
Was my first thing. So carpal tunnel, hallmark characteristics are numbness, tingling, burning, some nerve symptoms, generally on the palm side of the hand, most often in these two fingers, so the pointer and the middle finger, maybe a little bit into the thumb. If you're having pain, it's probably not carpal tunnel. If unless it's also accompanied with that burning and tingling. And carpal tunnel, again, because it's defined as basically it's median nerve, so it's the median nerve bundle that comes all the way down from the neck, down the arm, through the carpal tunnel in the wrist and into the hand. So since it's traveling that whole long pathway, it may or may not be the actual carpal tunnel that's the problem. It could be something at the neck or something kind of down the chain. It can be caused by leaning at your wrist. It can be caused by spending too much time with the wrist flexed or extended. I believe flexing the wrist increases the pressure in the carpal tunnel 8-fold, and extending the wrist increases it 10-fold. So having a relatively neutral wrist when you're working is actually important. So that whole ergonomic setup thing is kind of cool. That's why those wrist braces tend to help, because they're just cheating and helping you get there. I was actually talking to a patient the other day, totally unrelated injury, but it just kind of came up in conversation that he used to have carpal tunnel. And he's like, it's funny, I put on the wrist brace and it made me use my shoulder more. I'm like, So you can put a wrist brace on, and then when you take it off, you might go back to your old habits, or you might have learned. For him, he put the wrist brace on, and he realized all of a sudden he was doing electronics, so he was more in like this, doing stuff. And he realized that it changed how he was using his shoulder. He was like, oh yes, I use my shoulder much more instead of doing this all day long. So just kind of being aware of your movement can be one of the biggest changes you can make. And that's really where I come in. My goal, if I can give someone like no exercises and just tell them the things to change in their daily life, they're much more likely to do that than do all the exercises I tell them to do when they go home. So I am much happier to say, okay, so stop doing this and move the whole unit. And the reason I put other nerve stuff in there is because if it's not this, but it's still that numbness, tingling, burning, It could be one of your other nerves. Ulnar nerve is more on the pinky side of the hand. Radial nerve is more on the thumb side of the hand and the back side.
Could you? I think this has a diagram of the regions,
myotomes?
and because I saw it when I was flipping through.
Try medial nerve.
And I meant to mention that before because this is one of my favorite diagrams anyway that I had no idea about. Worst search.
It's it's user error. I'm not searching for the right thing.
Pretty sure it was in here somewhere. There was like one of the ones with.
This is cool. We were just talking about the carpal tunnel. This is the carpal tunnel.
Oh.
So, you've got this retinaculum there. So if they do carpal tunnel surgery, that's what they're going to snip. But you've got all the flexor tendons. So all of these guys here.
Is this hand? This is hand palm up.
This is hand.
Or what are we looking at?
This is your hand looking like this way.
Right, okay, so palm up from your side of the hand, from the owner's side of the hand.
So if you look at it's actually sorry, it's looking down into the wrist, but.
Yeah. Okay, so we've cut off the fingers and are looking back through it. Okay, got it. Oh yeah,
Delightful.
look at that. That's great.
Gotta love anatomy.
Okay.
So you've got all of these things in here are all your flexor tendons. So they're the muscles themselves are actually way up here in the forearm. That's why you get your epicondylosis up here. The muscles bellies themselves are here. Then they send down the tendon to actually attach into the hand and cause things like finger flexion. So they're all passing through there. And then you've got your nerves and arteries and stuff trying to pass through there too. So just kind of cool. I'm going the wrong way, I think.
It should be. It might be further down in the next. Yeah, here it is. They had a bunch
kind
of
of
these.
yeah. So here we go. So your median nerve is your traditional carpal tunnel nerve thing, and that's here in the red.
And that's traditionally carpal tunnel because that's the one that goes
that
through
is
the carpal tunnel.
the thing that goes through the carpal tunnel.
And the other
yes.
ones don't.
The
So
other
they
ones.
literally cannot be compressed at that tunnel.
Right.
Okay.
And then here's where you get your ulnar nerve in green and your radial nerve in blue. And then you can see on the back side of the hand, it's all blue radial nerve and ulnar nerve with a little bit of median nerve on the tips of the fingers, but rarely. If that gets bad enough in the medial nerve distribution, you'll get some aching in the forearm. That's usually just because the nerve which sends its signal down to the muscles to contract too. The nerves do all the information transmission isn't working properly and they can get achy because they're not firing properly. But so that's where you'll feel the different nerves, the most common ones anyway, in the hand. So if someone says they have numbness and tingling, I'm always like, where? And if they're telling me the whole hand, I'm like, well, chances are it's starting way up here in the neck.
Because that's the only place you could crush them all. Or sorry, not crush. Smush. What was this? Wasn't crush.
I like smush.
Smush. Okay. That's the only place you could smush them all
yeah.
at the same, in the same.
In one fell swoop.
In one fell swoop. Yes.
Yeah. Otherwise, you're going to get
have to do it in multiple places.
The ulnar nerve is here.
Got it.
They kind of branch out once they kind of come through that thoracic outlet. If you guys have heard of thoracic outlet syndrome, again, you're describing a symptom. Why do you have that pressure?
What is thoracic?
Thoracic outlet is that pushing down.
Oh, okay. That outlet is getting constricted. Okay.
Constricted there. But again, I care about not that that's where the constriction is. Why is it getting constricted there? Yeah.
Okay, so was that all for carpal tunnel and other nerve issues, or did you have,
that's kind of the general. Unless people have very specific questions.
I really don't know how to pronounce this.
De Quervain's.
Okay, there we go.
Yes, de Quervain's is another common one. This is one that people have pain when they're hitting the space bar. It does this. It's inflammation of the tendon right here. Let's see if I can just do it by this. Ooh, not like. It's not going to come up with that. I'm pretty sure I'll have to put the tendon name in, but yeah.
Yeah, this book doesn't have almost any symptom-based things, I don't think.
Let's try.
I'll actually cross off the ones we've gone over here, so I'll be able to. What is that?
What?
Oh, that's another slice
It's
through
just
the
we're
hand.
slicing through the hand here. We're getting down to the good stuff.
Rather gruesome. It's like a scene from a mafia movie or something.
So delightful. Yeah, that's what I want, but I want it from a different angle.
Someday, we will have a fully rotatable human atlas. Someday. I've always searched for this online. They have kind of like some really not particularly good ones, but
Oh, look, guys, a spine. Why that came when I was looking for polysis, which means thumb, I don't really know.
can we send this back in time?
That
to
was
an earlier
amazing.
part of the-
Okay,
We wouldn't have had that drawing of the smiling guy sitting though.
here's what I'm looking for. So these two tendons that kind of form that triangle, inflammation of those tendon sheaths is dequervant. But again, it's often the spacebar action, but it usually is indicated, like it indicates that people are moving weirdly in general. I actually, a nice example of this, just so you can kind of get an idea of what I see, is a young woman who had this diagnosis, this medical diagnosis, and whenever she would turn her hand over, like this. She'd lead with her thumb. And she wouldn't be able to turn it over as far as the other side. She'd kind of look like this when I had her turn her hands over. It's like, well, you're working way too hard. Stop that. So her treatment was keep your thumb in neutral and rotate your hand back and forth.
That was it?
That was it. And she eventually learned that, like, and she was able to then rotate her arm further, didn't have to work as hard to turn her hand over. And that worked for her in her circumstance. But it's just very interesting. You can see where people are kind of trying to find a way. She's like, I just can't get there. So she would use her thumb to kind of make up the difference. And it's like, okay, let's make it so you can get there so you don't have to use your thumb.
So, shoulder impingement.
Shoulder impingements. Shoulder
This is like the speed round.
I know, speed round.
I'm just
It's great.
shouting out a problem. Shoulder impingement.
Diagnosis. Shoulder impingement, again, where that's their medical diagnosis. It's not a physical therapy diagnosis.
Okay.
Physical therapy diagnosis can be like, what's causing the shoulder impingement? Shoulder impingement is the catch-all for, like, when I move my arm like this, it pinches at my shoulder, or I have that pain in a vertical line. It usually means the rotator cuff is getting squished. So
The rotator cuff, again, from what you described before, it's
we're going to look at it.
muscles. Oh, okay, like that are on the interior. So ones you can't really, feel with your hand.
You can't feel it.
Okay.
That's good, but it's somewhat hard to see. So that's a shoulder from the outside. That's your deltoid, not your rotator cuff. Your rotator cuff are these muscles that are really right attached to the scapula, which is this, again, this triangle here, and then your humerus coming down that way. And they kind of hug that humerus into that joint. Let's see if I can. Woo! Yeah, these are just hard to understand if you don't already know what you're looking at, is part of the problem. Where is what I'm looking for, though? This is pretty good. So this is looking top down, as if we were looking through the top of the head, kind of at the shoulder. So again, in the front here, collarbone. Back here, top of the shoulder blade. And in that top of the shoulder blade is the supraspinatus muscle. So that's where these stripes are. That pink bit is the muscle. This bulge here is the head of the humerus. It's the head of the arm bone. The supraspinatus comes under, so if you feel the top of your shoulder, you feel a bone right there. The supraspinatus goes under that bone. So you've got your collarbone, comes across. You've got your acromion process, that's the thing that sticks out. And if you come then back, on the back side of that, you'll feel soft, squishy muscle tissue. Maybe there's a knot or two there, but soft, squishy muscle tissue. That is your under that is your supraspinatus, which comes out underneath that acromion process. So if your scapula is not doing that nice motion, where it swings up like we were talking about earlier, your supraspinatus gets squished underneath that acromion process. And that's classically known as shoulder impingement. But again, that's great, but why is that happening? So it's great. So maybe it's swollen so much that you're getting impingement no matter what you do, but chances are that scapula's not moving properly. So that's shoulder impingement.
Then you just have neck pain and shoulder pain.
Yeah, just generalized neck pain, shoulder pain. Because again, those are the diagnoses that you get.
That you get.
Right? So neck pain could be from doing this, could be from doing this, could be because when you turn your head right, you do a weird thing, could be when you turn your head left, you do a weird thing. Shoulder pain, again, things not moving properly in there. Basically, it usually comes down to how you're holding yourself and how you're moving. There are some really cool, great studies out there right now about MRI results and, say, neck pain or low back pain. And it's basically like, yeah, your MRI looks nasty. But you're part of the group that we tested that's completely pain-free. So in normal populations, it was something like, depending on the age group, and I'm going to screw it up, so please look it up. It's something like in your 30s, it was like 70-something% had a weird anomaly on their MRI that if you went in and I said, I had neck pain, and you get imaging done, and they're like, oh yeah, you got this thing, it's definitely that. It's like, well, but normal population has that too. So again, though you may have anomalies on imaging, they don't necessarily correlate to your pain or symptoms. What tends to correlate to pain or symptoms is what you're doing in the rest of your body that may have caused that anomaly as well.
Oh, interesting. So it could be that the cause of the pain and the cause of the anomaly are actually
the same, or it could be
some
that they're
other thing
different.
that has nothing to do with the anomaly at all.
Yes.
I see.
So just because you have a bulging disc does not mean that you have pain.
I see.
So though we all, especially anybody who's science-based brain, love to have answers and images and all that, we need to kind of come to terms with the fact that that's just not how our bodies work. So we need to learn what it is that's actually causing our symptoms and kind of understanding it on a more global scope.
So we kind of need to just get MRI'd all the time so that we can see when these things actually develop and then go, well, all right,
Casey just single-handedly blew up our healthcare system.
Sorry. So we've got...
What I'm more trying to say is that conservative care and conservative management, which saves both the insurance companies money and you money, are actually the better way to go.
Fair enough. So we've only got a few minutes left here, so let's just end on, so obviously this is sort of all of the sort of stuff that's with diagnosis, figuring out where the pain could be, what it might be coming from, that sort of thing. So at the end of doing all of that work, you then obviously give people sort of activities to do, right? That's kind of the goal, like you were saying. It might be as simple as just like, hey, try to learn how to turn your hand over more or something like this, or it may be like a set of exercises, et cetera. So I just wanted to ask the question, are there preventative exercises that you recommend or preventative habits that you recommend? Because obviously if someone has one of these problems, they're going to have to go to somebody like you to sort of get the actual movement stuff worked out and go, okay, here's the exercises you need to do to correct that specific impairment. Mm-hmm. But prior to having a problem, are there things you can do that just keep your body in shape better that, decrease the likelihood of things getting into these bad positions, knowing that the person probably is like this most of the time? How do you counteract that? What do you recommend for that? And are there exercises you recommend people do daily or anything like this?
Yeah. So like I said before, I don't tend to love giving exercises, so I'm going to start with the two simplest things you can do. Yeah. Number one, as part of your daily life, try to change positions frequently. Don't get really settled and comfy in one position. Stand up, sit down, lean back, lean forward. You don't need to be like this all the time. I'm not one of those people who's going to tell you to do this because it's not realistic. You're at your computers a lot, but changing positions is really good for your body. It's really healthy for your body. You don't get stuck in that one shape. So that's number one. Number two is do anything, any activity that's not sitting down. Go for a walk, go for a run. I don't really care what you do, but do something cardiovascular. Getting your blood flowing everywhere and getting your body working globally and coordinating movement all together is the best thing you can do for your health, musculoskeletally, and global health. So those are my two, everyone should be doing those things. And they're relatively easy to do. As far as specific exercises go, I know everyone likes the specifics because it makes them be able to say they can point to that one thing and it's like, it's that thing, haha. I will again go with just one. Oh. I'll pick just one.
Okay.
Because I think It's easier. I don't love to give people giant lists of things to do because people don't do giant lists. They do one thing. Some people are exceptional. I find my tech workers sometimes, like my circus people, love to go to extremes. So sometimes I have to rein them back in. But basically, computer work all day, you're here. So that's relatively rounded in the torso, relatively shoulders forward, relatively internally rotated at the arms. The wrists could be doing all sorts of weird things. So I like to take people completely out of that. And my absolute favorite exercise I call the reverse wall slide, or a wall angel, is probably something you can find. It involves sticking your back flat up against a wall, which may mean your feet have to be a little further away. Your arms out to the side, about 90 degrees. Hands on the wall, but your elbows not on the wall, because most of you are stiff from doing this. So to get those elbows back on the wall, your shoulders are going to pop out. This is why I don't like giving exercises, because I'm so specific about how I make people do them that it's really difficult. So back flat against the wall, hands on the wall, elbows forward, shoulders relaxed, neck relaxed. If you can achieve this position, which is not going to be easy for everyone, then you can slide your hands up the wall and overhead. And the idea behind that is that you are opening the chest, bringing the arms out to the side, so you can bring your shoulder blades together, which is the opposite of here. So you're going to be firing the muscles between the shoulder blades. You're working your arms into external rotation, again, fighting this internal rotation position. It's also an active stretch for the pectoral muscles, just to get you back there, which is why the elbows will probably have to come forward. And then as you go up overhead, you're going to trigger in your middle and lower trapezius in your back, so back here. You're going to be stretching your pec muscles again as you go up overhead. Your lats are going to have to let go. Your external rotators are firing. So it's a lot of information, but the global idea is you're doing the opposite of this. So that's probably my number one favorite. End of the day or lunchtime, do 5 or 10 of them, exercises, and they'll keep you kind of moving and healthy.
Awesome. Well, we are out of time. Thank you so much. And also, you're going to be up at the reception or throughout the day?
I will be,
Okay.
yes.
So there's a Pure Motion banner, which is your company. And there's a Pure Motion banner up there. And so if people wanted to talk about specifics or get a business card or something like that, yeah, make sure you find it.
Happy to answer questions.
Thank you so much. That was fabulous.